Hello there, my name is George Thompson, and I'd like to thank the Arabic Association for the Study of Diabetes for the opportunity of giving this talk relating to the RAAS, that is the renin-angiotensin-aldosterone system in diabetes, including future strategies for treatment, particularly in the age of COVID-19. I think this is an important area because, as we know, there's been a lot of speculation since the advent of the virus that causes COVID-19 about the effect, either adverse or positive, of blockade of the RAAS system. And naturally, this has led to a lot of concern in our patients who have been asking lots of questions. I hope this talk may help us to answer some of those for our patients and colleagues. Understanding the RAAS in diabetes is important because we know that there is activation of this system caused by diabetes, both in response to hyperglycemia and also sodium retention. And through activation of the system, systemic blood pressure changes caused by vasoconstriction and also fluid and electrolyte imbalances can develop. As the next few slides will demonstrate, there are also adverse effects caused by activation of the RAAS system if it is not controlled through a variety of mechanisms and impacts on systems and organs throughout the body, including the kidneys, thrombosis, etc. This slide demonstrates a very simple schematic of the RAAS as we might have learned it at medical school. The liver creates angiotensinogen, which is converted by the secretion of renin from the kidney to angiotensin 1. Conversion by angiotensin converting enzyme of angiotensin 1 into angiotensin 2 leads to the predominant and often adverse effects of stimulation of this system. In effect, this is a very primitive system that we find in most organisms because injury leading to blood or fluid loss causes volume depletion, and mechanisms need to exist to prevent death or adverse effect from such injury. Thus, when the kidney senses a reduction in volume, it stimulates the system through renin secretion. And as you can see, the effects are multiple, but in effect lead to sodium, fluid, and vasoactive effects, which raise blood pressure and retain fluid and salt. When stimulated for the right reasons, this of course is protective, but where it is stimulated through disease or other unintended reasons, then adverse effects can accumulate. Like most biological systems, however, the story is not as simple as the previous slide portrayed, and in fact there are very clever mechanisms in the body to attenuate the effects of angiotensin 2, either through conversion of angiotensin 1 to angiotensin 1,9 through the ACE2 enzyme, or alternatively by degradation of angiotensin 2 before it can have its effect on cells, again via ACE2 to angiotensin 1,7. Interestingly, angiotensin converting enzyme not only converts Ang1 into Ang2, but also converts the 1,9 product of ACE2 into the 1,7 product. As you can see in this slide, the 1,7 product of ACE2 is in effect counteractive both to stimulation of the angiotensin 1 receptor, but also through stimulation of cellular G protein coupled MAS receptors to effects that are directly opposite to those of angiotensin 2 stimulation. As you can see on this slide, not only is angiotensin 1.7 protective, but also the previous 1.9 product working through the angiotensin 2 receptor also confers protection on the cells and the body in general. However, you will note from this slide that ACE2 plays a key role in the production of both of the protective forms of angiotensin, whether the 1.9 or the 1.7 compound. Understanding this process not only helps us understand where and why the angiotensin converting enzyme inhibitors or the angiotensin 1 receptor blockers might confer benefit in patients with activated RAAS systems, but also, importantly, in the era of COVID-19, why COVID may have direct adverse effects. As we know, COVID virus gets into the cells via binding to the ACE2 cellular enzyme complex, and both the enzyme complex plus SARS-CoV-2 then enter the cells, effectively reducing the amount of ACE2 at the cell surface. In turn, this, in theory, should have adverse impacts on the RAAS and potentially significant harmful effects for patients, which is exactly what we're seeing in COVID-19. Thus, in summary, ACE2 is protective and present in most organs, particularly the lungs, the intestine, endothelium, and smooth muscle. Interestingly, in animal sacrifice models where they have been infected with SARS-CoV-2, virus is found in all of these places. What is also interesting is that mRNA for ACE2 expression is found in neural tissue, and this may be a theoretical model to explain the common findings of loss of sense of smell or taste in patients affected with COVID-19. It may also explain some of the other neurological effects that have been described, and potentially long COVID. It has been known for some time that ACE2 itself is insensitive to ACE inhibitor blockade. However, use of ACE inhibitors or angiotensin receptor blockers increases ACE2 mRNA expression and also, in some cases, ACE2 activity itself. And this is why there was a lot of speculation at the start of COVID-19 about the potentially adverse impact of either of these agents on patients developing COVID-19, in whom it was assumed that the ACE2 enzyme complex might be overexpressed due to receptor upregulation, leading to an increased susceptibility and risk from COVID-19. Balanced against that, this rather neat systematic review and meta-analysis from 2012 demonstrated, I think fairly clearly, that in patients treated with RAAS blockade, there was a significant mortality benefit and indeed risk of severe pneumonia. Thus, from the start of the pandemic, there was a lot of speculation about whether RAAS blockade would prove to be a good thing or a bad thing in patients with COVID-19. It is important to stress, however, that COVID-19 is a different type of viral pneumonia and infection, and it cannot be assumed that in the 2012 meta-analysis, the pneumonias in question were either caused by viruses which specifically targeted the ACE2 receptor, or indeed that these were viral pneumonias in the first place rather than bacterial. Thus, the first findings in this area, based on observations through January and February 2020 in Hubei province, China, but not published until after the height of the first wave pandemic in most European and Western countries, suggested that prior treatment with ACE and ARB was protective in patients admitted to hospital with COVID-19. Specifically, this study demonstrated a lower risk of mortality in COVID-19 patients who were previously receiving ACE inhibitor or ARB therapy. However, a significant drawback of the study was that it was retrospective and relatively small in scale, including only 188 patients treated with RAAS blockers. A slightly later but much larger systematic review and meta-analysis of nearly 30,000 patients, however, added weight to the argument from the paper from China, and the authors concluded that patients with RAAS inhibitor therapy should continue on that therapy. This was based on a review of deaths or critical events as designated by ICU admission, mechanical ventilation or NIVI. And as you can see, approximately 1/3 of patients were on RAAS blockers in this meta-analysis. The reason the authors concluded that RAAS blockers should be continued in hospitalized COVID-19 patients is demonstrated in the first figure from their study. And if I can just highlight the hypertensive group outlined and the mixed comorbidity group outlined, you can see the reason why the authors concluded this from their study. If you want to read the whole study, it is free to view online if you click on the link on the previous slide. As we know, retrospective analysis and meta-analysis, whilst useful, are not considered the best form of clinical trial, and it was with great interest that the world watched the publication at the European Society of Cardiology of the first randomized controlled trial of patients with COVID-19 on prior treatment with RAAS blockade, which the authors presented on the 1st of September this year. The take-home message from this study was that it is safe for people taking an ACE inhibitor or angiotensin receptor blocker to continue the medication if they develop COVID-19. The study was conducted in Brazil and included 659 people taking an ACE inhibitor or ARB when hospitalized with COVID-19, of whom 50% were chosen at random to continue their usual medication, whilst the other 50% were asked to stop taking them for 30 days. As you can see, at the end of the 30-day trial period, 95% of the people taking their ACE inhibitor or ARB were alive and out of hospital, compared with 91.8% in the other group. Their results may not confirm that use of RAAS blockers are protective in COVID-19, perhaps due to the relatively small number of patients in each group. However, they are entirely consistent with the meta-analysis shown previously, and the authors conclude that people should not stop taking these medications and doctors should not stop them either. I'm sure you've had, during the course of this Congress, much more information about COVID-19 and its effect in diabetes. However, I thought it was important to stress the current state of knowledge in this field as I move on to talk about why RAAS system in diabetes is important. As you can see from this slide, in metabolic syndrome, which for most of us constitutes the predominant number of patients we treat with diabetes, the RAAS and sympathetic nervous system are activated, and we all know the consequences of the combined dyslipidemia, diabetes, high blood pressure, and hypercoagulability that we see in our patients. So does modification of the RAAS help our patients with diabetes? And in the next few slides, I hope to demonstrate without doubt that this is the case. One of the most often quoted studies is the MicroHope study, which investigated the impact of ramipril therapy, predominantly in the HOPE study, but there were sufficient numbers of patients with type 2 diabetes included in that study for the investigators to look specifically at the impact in those with diabetes. As you can see, the study was stopped early because of the significant reduction in so-called MACE events, that is stroke, myocardial infarction and cardiovascular death, witnessed in patients treated with ramipril compared with placebo if they had diabetes. Interestingly, in the HOPE larger group, it was also observed that the use of ramipril therapy prevented diabetes with a relative risk of 0.66 in those treated with ramipril compared with placebo. This slide shows the paper written by one of my ex-bosses, Miles Fisher, which shows this relative risk reduction, but I put the second figure into the slide to emphasize that the size of the risk reduction is small compared to that of lifestyle modification or metformin therapy. However, it's not one that we should ignore. I should emphasize that the previous slide and the present slide look at patients who do not yet have diabetes and the reduction in risk of diabetes in those treated with RAAS blockers for reasons such as blood pressure or heart failure, etc. What this meta-analysis neatly demonstrates is that the angiotensin receptor blockers have similar, perhaps not quite as great, benefits in diabetes risk reduction as the ACE inhibitors. And the DREAM trial, published some years afterwards, confirmed this benefit with ramipril, although in that study the benefit of rosiglitazone, which, as you know, specifically reduces insulin resistance, was greater than that of ramipril. So in the age of COVID-19, should we be initiating therapy with RAAS inhibitors? And for me, the answer is overwhelmingly yes. If we look specifically at diabetic kidney disease, where we know that a combination of blood pressure and high sugar causes increases in glomerular filtration and therefore proteinuria and ultimately kidney damage and failure, the benefit of the ACE inhibitors and angiotensin receptors, I think, have been clearly established, and other talks that I'm sure you've had or will have during this Congress will demonstrate that. I've put this slide in to demonstrate that there are lots of other agents available or potentially in development that influence the RAAS, in addition to the ACE inhibitors and ARBs that we are perhaps conventionally most used to using. In particular, I would highlight the availability of drugs that influence the aldosterone receptor and the potential benefit that these bring. In patients with heart failure, we know that drugs such as spironolactone have significant prognostic benefit, and we shouldn't forget about them in thinking about the RAAS and how we get involved in reducing the adverse effect of RAAS stimulation. I'm not going to dwell on the modification of the RAAS in diabetes because I'm sure that you have had or will have lots of other talks on this. However, I would just remind us that studies such as MicroHope showed a significant long-term benefit of ramipril in this case, but ACE inhibition, because lots of other studies have shown it, on the development and subsequent onward course of diabetic renal disease. And it's not just in the kidney that the inhibition of the RAAS system confers benefit for people with diabetes. If we look at the eyes, RAAS inhibitors are associated with both a reduced risk of progression of eye disease and also an increased possibility of regression of the changes that are already present, which in the case of people with type 2 diabetes is not an uncommon finding at the time of diagnosis. In this systematic review and meta-analysis, it is noteworthy that the association of the use of blood pressure lowering drugs showed that the greatest benefit was for ACE inhibitors, followed by ARBs in terms of progression of diabetic retinopathy, and for regression was similarly highest for ACE inhibitors, followed by ARBs. Turning then to what I think is the most exciting observation of the use of ACE inhibitors in type 2 diabetes is the fact that they appear to prevent all-cause death and cardiovascular death. This is a study published in 2004 from Canada, in which just over 12,000 patients initiated on oral hypoglycemic agents, in other words, developing type 2 diabetes, were included, of whom 3,200 patients who had prior cardiovascular disease were removed from further analysis. The authors looked at just under 1,200 patients who were on ACE inhibitor therapy and compared them with just under 5,000 patients who throughout the study period did not receive ACE inhibitor therapy. And these patients were followed up until death or the end of 1999, which represented anywhere between an 8 and 3 year follow-up period. And in summary, these are the results. And as you can see, over the follow-up period, both all-cause mortality and cardiovascular-related mortality were significantly reduced in those treated with ACE inhibitor therapy versus those not receiving this therapy in this Kaplan-Meier chart. And I think these data from Canada are important because they are very similar to the data published in Circulation in 2017, based on quite a number of different studies, which show, I think, quite clearly that if you look at the ACE inhibitor versus placebo group, cardiovascular and all-cause mortality death is reduced. However, what is interesting is that if you compare the ACE inhibitor group with those treated with angiotensin receptor blockers, the blockade of ARB does not confer the same death benefit. Thus, it does appear to be specifically related and linked to the use of ACE inhibitor therapy. The authors of this paper therefore concluded that logic dictates that practice guidelines should recognise the unique cardiovascular benefit of ACE inhibitor therapy and their preferential use in patients where RAAS blockade is appropriate compared with ARBs. Thus, in summary, and I must say this has been the strangest talk I've ever given, but these are strange times that we live in, so I'm sorry if I have rather rushed through things in the 25 minutes allocated. The RAAS inhibitors have, I think, a clearly demonstrated positive role for lots of reasons in people with diabetes. The ACE inhibitors, but not angiotensin receptor blockers, reduce all-cause and cardiovascular mortality in people with diabetes. The RAAS inhibitors as a group may help reduce diabetes incidence if you have to treat patients for other reasons with this group of drugs, but lifestyle for me still comes first. Personally, because of the data that I believe are compelling, the use of ACE inhibitors is always my first choice. And in those patients who are intolerant of ACE inhibitors due to cough, I would go for an angiotensin receptor blocker second, or add it in if needs be. At the moment, there are no studies at the time of giving this talk which address the potential benefits or harms of initiation of ACE inhibitor therapy or ARBs in patients that you are currently treating with COVID-19. And this statement is backed up by what is still on the WHO website, dated May 2020. However, there are a number of global studies ongoing, but only one of these currently is initiating a RAAS blocker, which is telmisartan. So the take-home message, I think, is at the moment, do not stop RAAS blockers in patients who you see for COVID-19, and hopefully we will have more information as further studies are published. Thank you very much for your attention, and I'm very happy to take questions either directly if the online link works, or alternatively via email, which I will endeavour to get back to you as soon as possible.